Ongoing concerns over the SGR fix, the Medicare Physician Fee Schedule for 2011, practice response to continued changes. What specific reimbursement changes will affect the community oncology market this year? And what best practices can be implemented to ensure that practices receive appropriate reimbursement for their work? Join us to find out. In the Know starts now. Hello and welcome to In the Know, your source for insight and analysis on the issues that matter to our dynamic healthcare market. I'm your host, Gina Clark. Today, we turn our focus once again to the community oncology space, specifically exploring what oncology practices need to know about recent changes in Medicare. We'll talk about areas where practices can take advantage of clear opportunities, as well as other areas like biosimilars, where some ambiguity still exists. Joining us to address all of this is Bobbi Buell, Principal for onPoint Oncology and a nationally recognized expert in oncology coding. Bobbi, thanks for being with us today.
Thank you, Gina.
So let's start a bit broadly. Can you give us an overview of what the current reimbursement landscape looks like for oncologists? And what is the reality that practices face?
Well, this year for Medicare is the first level year we've had in a while. We've been seeing the reimbursement drop really almost every year since 2003, particularly for drug administration services. This year we have a fairly level year for Medicare. It's pretty much like it was last year, except for, as we'll talk about later, the incentive programs have dropped by half. Both e-prescribing and PQRI, now known as PQRS, have both dropped this year. So you'll get less incentive, but you don't have to worry about your reimbursement dropping. We just did a study in COA on Medicare reimbursement for 2011, and most medical oncology practices are really looking at about a 1% increase. So that's nice. It's better than the alternative, but again, you have less reimbursement incentive. As far as the total reimbursement landscape looks, how it looks right now, you really have to think about bundled payments. We're going back to the 90s, where we looked at capitations and physician hospital organizations and all kinds of bundled payments. And we're seeing that again in some of the Medicare demonstration projects for accountable care organizations, which are the old PHOs, medical home, which is really primary care physicians, or oncologists. I like to call oncologists the patient's second home, because when the patient has cancer, their oncologist becomes their medical home, and other bundled payments such as United Healthcare's episode of care payments. And there are episode of care payment demonstrations for Medicare also, but none in oncology. So we're going to be seeing all these various and sundry efforts, both by public and private payers, to bundle payments.
Wow, it is very, very reminiscent of the 90s and what we all went through back there.
And it didn't work then, so I don't know why anybody thinks it's going to work now.
Absolutely. It is curious for those of us that have been in the field all this time to say, what are they doing differently to administrate this time and to manage this process? I think we'll watch as it unfolds. But back to kind of what you're seeing right now, what are the top 3 concerns that practices are facing? I would assume that health reform would take 1, 2, and 3, but what additional insight can you share?
Well, I think there are 3 major issues that people really have to be looking at this year. 1 is systems, and we'll talk about that more in a minute. 2 is audit risk, because the government is really trying to make up money by taking it back. And the 3rd thing really is still cash. So I'll go through each one of these in a little more detail. The first thing is everybody is very fixated on EHRs and EMRs for the meaningful use incentive. And I think that's only one thing they have to worry about this year. HIPAA 5010 is coming in January 1st, 2012. This means all of your systems have to be 5010 compliant. And a lot of people have ignored this because of meaningful use. But you're looking at a 1-year time frame, and Medicare has published all kinds of help and rules and everything, and people have to be very vigilant about this because all of their systems where they have data interchange have to be 5010 compliant. That means your billing system, your clearinghouse, your remittance data, all of that must be 5010 compliant, and the time frame is very short. The reason that you have to be 5010 compliant in 2012 is because in 2013 we're going to have our ever-loving, wonderful ICD-10. You know, I'm targeting 2013 as my retirement year for that reason. But people have to start getting smart about ICD-10 and how it fits into your systems and how it fits into your EMR and your documentation. Very, very important. And of course you have to worry about EMRs because you have to be compliant with meaningful use to get the full incentive before October 1st of 2012. So for EMR implementations, that's not a lot of time if you haven't started yet. So those are the systems things that people really have to worry about this year. In terms of audits, there are all kinds of audits going on. There are CERT audits, which are audits of your MAC or your carrier. There are RAC audits, of course. Everybody's talked about RAC audits for years, recovery audit contractors, and there haven't been very many for physicians yet, except for units of drugs, which are being looked at. The other thing is your MAC can do prepayment or post-payment audits on you at any time, and then there's the Office of Inspector General and the fraud police, who are sometimes known as the ZIPICs. And now there are Medicaid audit contractors, known as MICs. So there are so many people auditing claims that you must have a compliance program in your practice. It's key that you start to pinpoint all of this stuff before somebody does. And per health reform, once you find something, if you owe the government money, you have 60 days to give it back. And once you find it, you have to find a way to give it back if you have been overpaid for any service, particularly units of drugs, which I feel are going to be a specific focal point this year. We have these other audits going on called MUEs, which are hard edits, and they just kick claims out right away. We have one right now on Faslodex, on 5-FU, on ePoetin alpha, and possibly on Sandostatin. So we're looking at the government being very focused on the units of drugs that you bill. The third thing I think people have to worry about is an insurance trend that's going on throughout the country called high deductible health plans, HDHPs. HDHPs are getting wider adoption every day. I personally have an HDHP. My deductible is $3,500. And the big problem for all practices is in the beginning of the year, like right now in the first 3 months of the year, there's no cash coming in with all these high deductible health plans. And I expect that trend will continue as health reform mandates insurance, if it in fact does, for people adopting higher and higher deductible health plans because health insurance is going to go up. It's going to continue to go up. So it's something that you start the year in a cash deficit, and it's very, very hard to make it up. So practices have to have really good cash forecasting within their practice.
Turning our attention to the Medicare fee schedule for 2011, what information can you share with practices about significant changes they will see this year, either positive or negative?
Well, the nice thing about oncology this year is we were rather level, and that's the good news. The bad news, as I said, is the cut in the incentives, because people did very well on the e-prescribing and PQRI incentives last year, particularly the larger practices. A lot of money was earned in those areas, and they have been cut in half. Some of the things that people really have to look for that, you know, they aren't so well known is if you have imaging in your practice, you have to give every patient, every time they come for a referral, whether it's a repeat test or not, they must give the patient a referral form talking about 5 other facilities that can do this imaging. The other thing that is in there, but it's been stalled until April 1st, is that practices must have signatures on all lab requisitions, not on laboratories that are done in your office, but if you're going outside for a laboratory, it must have a physician's or a non-physician practitioner's signature on that. They're not going to start enforcing that till April 1st. So that's very important. And we'll talk about some changes in e-prescribing and PQRS that there are for next year, but those are absolutely the biggest changes. There really haven't been any major coding changes, nothing major like elimination of consults and things like that, just a lot of little stuff. But Medicare, one other emphasis is Medicare has a real emphasis on signatures. So people really need to audit the signatures on their charts, whether they're electronic signatures or whether they're physical signatures, particularly on orders, because if you are audited by Medicare and there's no signature on your orders, that order is considered invalid. And if you're ordering up a whole bunch of drugs, that's not a good thing.
Well, then that leads me to my next question. With so much changing year over year and in some cases month over month basis, how can practices realistically keep up to ensure they are compliant with all these changes?
I think it's very difficult. I mean, it's a difficult feat for me, and that's my job. So it's very, very difficult. What they have to do is read everything they possibly can read. And it's sort of like exercise and diet. You have to pick the things that you like to read, the things that you want to read. We publish a newsletter that goes out to 3,700 interested oncology parties, and most of the practices do subscribe to our newsletter because it's free, because it's been sponsored by outside entities for a long time. But also Part B News is a very good source of information, but it's very expensive now. It's over it's $540 a year. So but it comes out every other week. It's very informative. Going to all the lectures that ION sponsors for you. We do webinars for ION, other people do. Your ION gatherings, your state societies, if you can go to MGMA meetings, you just have to try to absorb everything you can. It's very difficult.
So shifting gears a little bit, one area that seems to have received some increased focus in the 2011 Medicare fee schedule is biosimilars. Do you feel there's enough clarity in how the payment rules for biosimilars are defined? And what guidance would you give to practices about this?
Well, at this point, it's very difficult to give them guidance. Medicare was pretty specific in the rule as to how it was going to be reimbursed. It's going to be the weighted average of all biosimilars in that category. But, you know, the kicker is it's 6% of the reference product that's going to be added to it. So if you have a weighted, let's say it's a biosimilar of onPoint and alpha, just as an example. I don't know what the first biosimilar is going to be, but because there's lots and lots of people working on it. But, you know, so let's say it would be a weighted average of all NDCs in that category plus 6% of, you know, Amgen's onPoint and alpha or J&J's in cancer. So one thing that isn't clear is each biosimilar that comes out going to have its own J code? That's the thing that's really not clear at this point. It's also not clear for both biosimilars and generics if they're going to keep allowing them to have this two-quarter situation until, you know, all the NDCs are factored in and until the price drops out the bottom. There was a study that was done by the OIG recently that really looked at that two-quarter window and said, you know, Medicare could save a lot of money if they did the weighted average the first quarter and published it, or if they did monthly ASPs. If they did monthly ASP calculations, everybody would go insane. But that's something that's risky when biosimilars come out because that wastage of money that they perceive is going to increase.
You know, Bobbi, great information as always. Thanks so much for taking the time to have this discussion. I'm looking forward to hearing more of your thoughts on PQRS and financial implications of some of the practice-facing tools in part 2 of our conversation.
Thank you, Gina.
And thank you for joining us. Come back to knowledgedriven.com in a couple of weeks to see part 2 of our discussion with onPoint Oncology's Bobbi Buell. Until then, if it's on your mind, it's in the know.